to frame our discussion today, what do we mean by health benefits policy? I think this is where we have the beginning of the chance to operationalize commitments to UHC, universal health coverage. It is the definition of the services and commodities that the government is going to use public funds to pay for from food sources. And it's also the kind of the rules or the processes for people to access those services. So it's about prioritizing, it's about financial protection, and this other piece about aligning the commitments with financing. So we have a great discussion today, and maybe just a few more framing thoughts before we dive in, what we're going to actually focus on in this session. We can have the next slide. So, as I mentioned, we think about benefits policy as a way to articulate and formalize UHC commitments. What does the population, what are they entitled to receive with financial protection? And to think in this moment about aligning that with available resources. And that's where priority setting comes in. And there's been a lot of dialogue over the last almost 10 years, I would say, around priority setting. What are the kinds of analytics that can be used? What are the processes? There's a lot of work that has been done with IDSI, the Center for Global Development, on helping to formalize that process, make it evidence-based. And so what we'd like to talk about in today's session is how the accelerator has worked to support countries to translate that evidence and normative guidance into the realities on the ground, actually how to take steps toward defining or expanding benefits packages and aligning that with financing. So aligning the commitments with available resources, but also the more practical part about how to actually purchase those services, how to pay providers to deliver them, and all of those aspects of operationalizing some of the normative guidance. So that's what we're going to focus on today, and we have 3 really exciting examples to dive into that will bring a lot of this to life. So the first example that we're going to hear about is from Ethiopia, and this is recent experience where the government looked at their exempted services, so the services that are free, they don't require co-payments or fees to be paid, and what the government commitment is for commodities around those. And this conversation was spurred by really kind of the writing on the wall from the donors that there would be transition, less donor support, and the government having to prioritize what they were going to pick up and commit to. And we'll hear about that process and how the government led a stakeholder process to get to that prioritization of commodities to be funded through domestic sources. And then we're going to hear about some ongoing work in Ghana. And this came about as part of bringing Ghana's universal health coverage roadmap to life and looking at the importance of primary health care in achieving UHC in Ghana and of course elsewhere. And I think stakeholders realizing that the main vehicle for UHC in Ghana is the National Health Insurance Scheme, which is currently mainly focused on curative services. So there was a discussion about how to bring prevention and promotion into those benefits. And then finally, the example from Georgia came about with some attention being brought to services around rehabilitation and realizing there was a very big demand for these services and that wasn't quite yet covered in benefits. And so starting a process to bring at least outpatient rehab services into the benefit package. We're going to hear about all of these examples from our panelists. And I just wanted to say that these are all examples of expanding government commitment. So it's not starting from zero, building a new benefits package, but expanding commitments. And that is always not just a technical exercise, but highly political. So we're going to hear a lot about how to bring together the technical and the political in these processes to get to something that everyone felt was a step forward. So with that, I'd like to introduce this excellent panel that we have with us today. Sorry, I thought we were going to have the panels. Yes, there we are. Okay. So sitting to my right, I'm very, very happy to welcome Elizabeth Hama coming to us from Ghana, who traveled to be with us for this event. And Elizabeth has more than 20 years experience working in program implementation, monitoring, evaluation in the health sector with various international organizations. She's an associate director at R4D with the Accra office of Ghana team and has been leading the engagement with the government in Ghana on operationalizing the UHC roadmap. And as we heard earlier today, the networks of practice, and as part of that, the essential services and the health promotion and prevention package. And online, we have Yodi Tesfaye, who's going to speak to us from Ethiopia about the work that's going on there, about prioritizing commodities in the exempted services package. Yodi is with the Ethiopia team at R4D. She's a program director on the market shaping practice. So she's been working for 14 years plus on bringing access to essential commodities, both in Ethiopia and across Africa, and has been leading the engagement with the government of Ethiopia on various aspects of access to commodities and their financing. And then finally, we have Dr. Akaki Zaita coming in from Georgia. And Kaki has been working for 25 years in health system strengthening, health reform in Georgia, but all across the world for many different organizations, advising UN agencies, the Global Fund, World Bank, and others, doing a lot of health reform work in Georgia, but around the world. So we have a great panel. And I want to thank those of you who are coming in from far away. It's late right now in Ethiopia and in Georgia, so thank you so much for being with us and joining our panel. So I'm going to jump right in and ask Yodi to maybe share first the experience in Ethiopia. I'm going to ask the same question of all of our panelists. Since we are talking here about expanding government commitments through this benefits policy, I would love to hear about how that got onto the policy agenda. So Yodi, how did this get onto the agenda? And then once the discussion about government funding for these commodities was on the agenda, there had to be some prioritization within that. So if you could share with us about how this got on the agenda, what stakeholders were involved, what kinds of analyses helped the discussion, and how that went.
Thanks, Cheryl. Hi, everyone. Good to see you all. From the Ethiopia aspect, the government of Ethiopia has been implementing different initiatives that aim to improve the life of the population through designing and implementing different health improvement packages or reforms. Among those reforms, the exempted health service is one of them, which is expected or designed to be provided for free for all users who are care seeking at the public health facility level. So this exempted service has been implemented through the major support from external donors, saying the services are provided for free for all patients who are seeking care at the health facility, or especially at the public health facility levels. When we look at which are these exempted service or free service, it includes family planning, MSH, NTD, nutrition, and the common HIV, TB, malaria programs as well. When we look at where are this funding coming from, majorly external donors are the major contributor, and government has a limited share for this exempted service provision. When we say exempted service provision, there are a lot of medicines and medical supplies and consumables that's required at the health facility level to provide these programs for free. So all those services contributed a lot on reducing the mortality rate for mothers, neonates, children, as well as improving the life of the population in general. However, in the last few years period, the donor support are declining significantly. Even if the donor has been giving an alert or a notification for the government to take full leadership on the resource mobilization and allocation, the ownership from the government side wasn't as expected or strong enough to take over the whole responsibility of resource mobilization and allocation. But in the last few years period, donors, beside giving a notification or alert for the government to be ready or to be prepared for being responsible to the resource mobilization allocation for this exempted service, they start declining significantly. So that was very much provoking, as well as it promoted a lot of discussion within the ministry, as well as within the government in general, including the Ministry of Finance, to think about what should be done on ensuring sustainable financing option design for those exempted service. At the same time, the kind of strategy that should be in place to transition from donor-driven exempted service package to the government-driven exempted service package, given, as you all were aware, like most of the funding that comes from the donors has been used for procurement of those life-saving commodities to provide the service for free, given the government take full ownership for the human resource aspect of the investment. So the most igniting or the most provoking action was donors significantly start declining the budget in the government to realize the importance of designing those sustainable options, at the same time to acknowledge the importance of prioritizing those exempted services that will give a government as well as donors in the major government, Ministry of Finance and the others, to think about what innovative financing we can think of as a country, so that the transition from the donor to the government is well strategized. So as part of this situation, the Ministry of Health established technical working group to support her and to support her team to expedite these efforts, designing sustainable financing option, at the same time starting from prioritizing the exempted service package that should be continued to be provided for free at all levels. So this TWG is composed of donors like USAID, implementing partners like R4D. We have representatives from private sectors as well, and we engaged different department and program leads within the ministry, as well as the Ethiopian health insurance agencies, to collaborate on the prioritization of the work, at the same time to get their buy-in, so that those selected exempted service would be fully funded by effort that the government will lead for the resource mobilization and allocation, at the same time identify intervention that can be integrated into the health insurance scheme, as well as define intervention that could be out of pockets as well. So these are the situations that ignite the need of designing sustainable financing option, and for the government to think about how to strategize the transition from donor to the government.
Thanks, Yuri. And maybe just one more question for you. Just the kinds of data that the TWG looked at to help with the prioritization process. Can you share a little bit about that?
Sure. The starting point was our starting or reference book was the exempted service legal framework and the essential health service package that's defined to be provided for free. That was our starting point. When we look at that essential health service package, it was more than 500. So the first thing was packing and packing intervention that can be merged as one, and also excluding intervention that didn't require medicine or supplies. That was one of the starting point. And at the same time, when we do the prioritization, we developed a criteria to prioritize one intervention over the other. So the one of the criteria was DALI, the disease burden, which is the proxy of public health importance. The other criteria we use is cost effectiveness, the average cost of the intervention. And the third criteria we use was utilization rate. The more the utilization of that specific intervention, the more that is required to be provided for free at all levels. So those are the criteria, and in our base was the essential health service package. But we use a global level as well as country level return on investment analysis that's conducted. And we projected the need of the commodities for the next 5 years. That should be part of the exempted service in monetary as well as in quantities as well. But when we do all this process, we engaged key stakeholders from the government as well as from the partner side to get a buy-in, but at the same time, it ignites a discussion between the Ethiopian Health Insurance Agency and the ministry. And there was a big debate on the criteria that we used to define the exempted service and the criteria they used to categorize the health service package and the exempted service in their benefit package as well. So there are still some issues on the air that requires more alignment, more engagement, but those are the key data sources we use. And as the accelerator team, we played a major role on leading a different analysis that should happen as part of the intervention on the projection of the forecasting, monetary-wise and in quantity, as well as on exploring different cost effectiveness analysis and return on investment analysis that's conducted in ET as well as globally in DALI burdens as well.
Thank you, Yuri. I think very interesting example of the donor transition triggering this priority setting process and having a holistic approach to looking at the sustainable financing of exempted services, and then going deeper and deeper as you had to prioritize. Elizabeth, I'm going to turn to you now and that what's happening in Ghana. If you share a little bit about the health promotion prevention package discussion, adding that to the National Health Insurance Scheme, what brought that onto the agenda and how that priority setting process went within the package.
Thank you very much. So I believe that what really triggered this whole conversation about changing the benefits package in Ghana was findings from a mapping exercise that was conducted, which showed that about 50% of services in the essential health service package are not covered by the National Health Insurance benefits package. And when these findings were presented to stakeholders, I mean, there was consensus that if Ghana wants to achieve UHC, we have, you know, we have a UHC agenda 2030, and we have launched our roadmap. So if we really want to achieve UHC, there's no way that we cannot include, you know, these services in the National Health Insurance package. So that is, I think that basically in Ghana, there's the understanding, I mean, it is known that the National Health Insurance package is heavily, I mean, it's skewed towards curative services. But the findings actually, you know, sort of brought it out that it's like 50% of the services that you want to use to achieve UHC are not covered. So it was something that jumped out, and there was consensus that there's a need to engage on this to make sure that it works. And the reason why, you know, this resonated with people was the fact that in developing the essential health service package, Ghana deployed, you know, a very, let me just say, broad-based dialogue, stakeholder consultation, consensus building processes. It brought on board a whole lot of, so apart from the mainstream service delivery agencies like the Ghana Health Service, like the Christian Health Association, like the private health providers, the process for developing the essential health package brought together, you know, stakeholders from academia, the pharmacy council, the nurses and midwifery council, even in engaging the service delivery agencies. The various levels of care were all considered and consulted. It was a very broad stakeholder engagement. And at the end of the process, you know, the essential health service package was actually endorsed by all stakeholders. So there's really a commitment to get it implemented. And so following that, we had this harmonization exercise to actually align the EHSP, that is the Essential Health Service Package, with the NHIS benefits package. And that is where, you know, this revelation came. And so there was then the need to start talking about expanding the benefits package to include these services. And as I mentioned earlier, most of these services were actually preventive and promotive services and interventions. And so the consensus was that if we really want to achieve more, we then need to bring on board these preventive and promotive services into the package. And I mean, because essentially they are not too costly, you know, and yeah, so basically that is what triggered the whole conversation. And what we did to support the Ministry of Health and the Ghana Health Agency to move forward was to set up a technical working committee. We identified some local primary healthcare experts, you know, some retired, you know, some still in service, who were brought together with other key stakeholders, including the National Health Insurance Authority itself. And we went through a series of, let's say, working sessions. It was, you know, series of sessions first to actually define and tease out all of the preventive and promotive services in the benefits package. That was done with, you know, a team of stakeholders, including implementers, frontline service providers, and then, you know, district level health managers included. And then there was a broader stakeholder engagement, which now looked at the first step was to define a roadmap for moving, these preventive and promotive services from paper to actual delivery of services to the population. So looking at what are the services that needs to be prioritized, what is the mechanism for purchasing these services, how are they going to be delivered, So we went through, it was a process, to actually define all of these things, what resources would be required to deliver the services, the combination of funding sources that would be used, how the funds will flow, and even how to track, the process, the HVPDP. So the first step was actually now to define all of this, like as a roadmap. This is how the process we're going to go through to, And then the second step was now to come up with a criteria for prioritizing the services. And so we came up with some health impact criteria, financial impact, sustainability, even political will to get these, the feasibility and availability of these interventions, issues around equity, all that. And then the third step was for us to apply the health impact criteria which looked at, addressing the leading causes of mortality and morbidity, the disease burden and public health impact, demonstrated effectiveness, and all that. Using the IHME data for, the top 10 causes of death. So the stakeholders actually prioritized, I think, 68 services were prioritized. And we had about 199 preventive and promotive services overall. The EHSP had about 450 something services. But then the preventive and promotive services interventions were around 190 something. And through the process that I discussed earlier, we were able to prioritize 68 services. So
Thank you.
for now, that is where we are. We have that package, done.
Thank you, Elizabeth. I think that so a slightly different trigger that got this on the agenda, looking at your own data and the gap between the essential services package and what was actually being covered by the NHIS, and finding out that missing piece was largely health promotion and prevention. Kaki, I'm going to turn to you and ask you the same question. So how did the issue of expanding the package to cover outpatient rehab services get on the agenda in Georgia? And then how is the prioritization happening within that to get to where you are today?
Good afternoon, everyone. And I would say the Georgia case is a kind of an illustration of one of the well-known theories about multiple stream theory of agenda setting. I would say where problems, politics, and policy solutions that coincided to open the window of opportunity to really make a qualitative change in policy, namely introducing public financing for adult rehabilitation services as a part of the Georgia's movement towards universal health coverage, to which the government has committed itself by introducing a universal healthcare program back in 2013, and increasing the population coverage from like 40% to 94%, with mostly hospital-oriented services, with less generous package for primary health care, as it happens, because of the political influences sometimes that providers demonstrate, or certain preferences that the population may have in when prioritizing. Georgia doesn't have any formal process for like health technology assessment or like benefit package design, but basically we had to think about this kind of priority setting based on, so we had to design it from the scratch, basically. and to decide, considering huge unmet need, which was the problem, and the census, the last census showed that about 1.5 million people, or about 40% of the population, had at least one condition that would theoretically benefit from rehabilitation services. So there was a huge unmet demand, and there was no public or private insurance coverage for rehabilitation services available. So patient out-of-pocket expenses were mostly spent, if any, on rehabilitation services. Huge barriers in terms of the human resources and specific shortages of specific specialties, standards, care guidelines. So all this has been a problem, systemic issues, systemic factor that have been preventing inclusion of the rehabilitation services under the public finance, or expand or integrating rehabilitation services in the national health system. I mean, for children, there was a limited package of rehabilitation services financed through the social part of the ministry, not through the health, let's say, health agency that finances the health services. But I guess that what happened that in 2017, the leadership of the ministry was so everybody recognized there was a huge problem. Political commitment was secured. The political stream was like initiated or converged with the problem stream once the leadership of the ministry participated in the first meeting of WHO on Rehabilitation 2030 call to action, and they got inspired with the idea and asked WHO to be a collaborative partner in introducing integrating rehabilitation services in the national health system. And then this political commitment also was strengthened further on with the engagement of being engaged with development partners like WHO and USAID, which also financed a partnership between Emory University and the Tbilisi State Medical University, and constructed a center of excellence for rehabilitation in Georgia, and also trained the human resources as kind of as exemplary to show that this is really how the high level or high quality rehabilitation services could benefit the population and could benefit the beneficiaries. So that was another piece of the contributing factor to this opening window of opportunity. And finally, WHO team in collaboration with the ministry had designed, in the widest circle of stakeholders, designed the rehabilitation, did the assessment, so-called STARS assessment on rehabilitation needs, on needs for integration of rehabilitation services in the national health system. And based on that, rehabilitation strategy was designed. And part of that political commitment was issued from the ministry that they will finance the adult rehabilitation program and include that in the universal healthcare program. But then was the issue which, considering huge unmet demand and absence of data on which services are available, what are the best practice guidelines on rehabilitation, and the inheritance and legacy of the Soviet or socialist times when rehabilitation was mostly considered spa services or massage or some kind of mat therapy, rather than evidence-based interventions that would benefit and prevent disabilities and improve the quality of life and functioning of let's say 40% of the population, and it was kind of considered only a service for people with disabilities rather than for people for beneficiaries or patients that would benefit from rehabilitation services, precisely by not becoming by not developing the impairment that will result in permanent disability. So that was the like a key challenge that we had. So what we used in terms of the data to try to prioritize the services to make sure that whatever limited, and it's always the finances are limited, as you know, no matter how rich the country is, it's always limited. So to prioritize what we could spend the limited services on, so the idea was to use the approach that we kind of global data, but to adapt it to the national realities and use the national statistics as much as possible for then costing those services. But the idea was to use the global burden of disease study and also the data from Institute of Health Metrics and Evaluation for Georgia to define those those health conditions that are amenable to rehabilitation that could be prioritized considering the burden of disease that they cause in terms of both years lost, but most importantly in terms of the years spent with disability. So this has been the key, one of the first starting point to see what is the burden of different health conditions. Then based on that, to decide using the WHO's package of rehabilitation interventions developed for specific for these health conditions, which has been happening in parallel to us doing this benefit package or prioritization exercise. And so WHO has shared with us the draft package of interventions to see how their package of interventions, as like basically these are the guidelines, but they are not calling it guidelines, they call it package of recommended rehabilitation interventions, how this could be used by the national governments to basically adopt and integrate in the rehabilitation services and rehabilitation interventions into their health systems. So we used their package as a case study, basically, and engaged the local experts and also looked at the cost effectiveness studies of rehabilitation interventions, along with evidence, which was derived from the WHO PR, whether these interventions are evidence-based. Another layer was as well whether these interventions are cost-effective and affordable for countries like us, like Georgia. And the third layer or third filter was as well whether these interventions, those that are cost-effective and medically or evidence-based, are whether those are available in Georgia and could be supplied, and if there are human resources and infrastructure able to supply that throughout the country. So that was the third filter. And finally, the expert opinion also used of local experts, whether these interventions and health conditions are a priority as well, not just from the global burden of disease, but also from public health importance, and considering also visibility of the first, let's say, exercise of setting this. For example, because in terms of global burden, lumbar pain is really the number one worldwide, that basically in terms of the priority. However, starting with lumbar pain, with that was not considered as a priority, considering that that these interventions were not really developed. Those that are like combination of psychological and and physical therapy interventions that are currently considered evidence-based is not that developed in Georgia. Second, the demand might have been very huge, and considering that there is a priority and there is a competing priority, so we decided to start with like several more, let's say, neurological conditions, fractures, and orthopedic conditions were finally decided to be of the highest priority. And then we developed the interventions based on grouped interventions that were recommended by WHO PR into larger groups to cost them. And use the data as we didn't have any utilization and cost data in Georgia. So use the data from Estonia, which had established payment system for rehabilitation service in 2005. So it was like a 20-year data, and with a comparable and did the activity-based costing, basically looking at it's basically the staff time if we talk about rehabilitation services, and as well then the indirect costs related to that. So this kind of multiple step process, gradual process was used. Then this was all validated with the stakeholders that included representatives of the providers, academia, first of all, beneficiaries, patients and their families, and also experts that had experience in providing the services not only in Georgia, but elsewhere, so international experts as well. So this has been then validated through this process. And finally, we came up with a cost proposal and priority conditions that the ministry then used to gradually expand, and the benefit package basically introduced the rehabilitation funding for adult population.
Thank you, Kaki. It's really the great story from beginning to actually getting to this put into practice, which I'll come back to again for more details on that. But maybe just to summarize what I've heard from the three of you about getting this on the agenda, there were different triggers in each of the countries. So the trigger of the donor transition, triggering it in Ethiopia, some locally based analytics in Ghana that really showed a mismatch between the services that were needed to achieve UHC and what the NHIS was providing. And then in Georgia, it sounded like a combination of some international advocacy from WHO, that report coming out in 2021 on the Rehab 2030, with your own analytics looking at the unmet demand. So those triggers were coming from different directions, but we're able to get this on the policy agenda. You all talked about quite extensive stakeholder processes, engaging many stakeholders, including service providers and others, academia and patient groups. But then just the last point I think that was really interesting that came out in all of your discussions was, once you had this on the agenda to expand the package in this area, you have to prioritize because financing is not unlimited. And you all, I think, Kaki, you used the words, but you all described a process of multiple filters. So the first filter is, what are some of these health impact criteria and utilization and forecasting the need, but that was still too much. And you had to keep going down the filters to get to what you could actually think was feasible within the resources available. And the criteria that you use for those filters were very much locally driven by stakeholders. And that you had that process to make those value judgments, what criteria would be appropriate. And then you used a combination of externally generated and internally generated data to apply the criteria. So I think there were some very interesting parallels across the three examples. I want to come back to all of you now. Let's fast forward to operationalizing these packages. And Kaki, you gave us a little preview. I'll come back to the Georgia situation. But Yodi, in the case of Ethiopia, you mentioned that you got to some commitment by the government for which commodities for the exempted services they would fund. How did that play out in practice? Where are things now? Has the government been able to meet that commitment? What challenges are you facing? And just in 2 or 3 minutes, where do things stand now?
Great, thank you, Cheryl. So as I said, from the 500 something intervention, we reached 106 intervention, well selected, prioritized based on the criteria. So when we changed it into monetary wise, and we presented for the Ministry of Health one clear direction, Ministry of Health and Ministry of Finance, one clear direction we get is taking into consideration the physical constraint that we are facing as a country and competing priorities among programs. They gave us a direction, excuse me, they gave us a direction to come up with short, medium, and long-term plan. So at the short-term plan, as I mentioned, the most critical program that's affected by the donor support decline is maternal, neonatal, and child health. So accordingly, our short-term plan is defining the monitoring need for the next 3 years, specifically for maternal, neonatal, and child health program, and define the share among the government, implementing partners, donors, / regional health bureau sites as well. Given the regional health bureau, they have been receiving this exempted service for free. They are very much enjoying that the government at a national level is taking full ownership for exempted service with the donors' external fund support. So they were like very much disconnected when it comes to financial commitment. So the way we designed the responsibility across the government and the donors is, for the next 3 years, the government for this fiscal year, for the upcoming fiscal year, we are in 2017, Ethiopian fiscal year, since we have like some calendar difference so for that 2017 fiscal year, which is 2024, 2025, we allocated, or we categorize government should be responsible for 20% of the need for MNCH commodities, and 60% of the need should come from external funders as well, 15% from the regional health bureau, and the remaining 5% through implementing partners who have bilateral engagement with the government. So that presentation is well accepted by the government, and for the upcoming Ethiopian fiscal year, the government committed 20 million in USD, 40 million USD, 14 million USD, which is fulfilling the 20% commitment that is defined by the TWG members as well, which is like a great win, given that when we compare this 40 million commitment from the previous year, it was 1 million only. So it's a total shift that the government show full commitment to take over the transition smoothly, but still 60% of the need is expected to come from external sources. We have SDG pool fund that can contribute to some extent, but still there is some big gap. We need to mobilize more resource from new donors or donors already in our landscape to contribute for that 60% need. At the same time, there is an assignment for the TWG and for the Ministry of Health to get a buy-in from the regional government sides as well, given they are very much autonomous. And we defined, or we suggested 15% of the budget should be coming from the regional health bureau. So this 20% share for the next year will be improved to 30% and 40% by year 3. So by the end of year 3, the plan is we will have to work toward this to the medium to long-term intervention, which is developing resilient and health equity fund, which will give more room or autonomy for the Ministry of Health to mobilize more resource domestically through implementing innovative financing option and other innovative financing mechanisms in place, and also trying to design or strategize their engagement with the donors through co-financing or match funding in a very accountable and transparent manner. So we get a commitment on the 20 million for the next fiscal year, which is like a big win, and we will move forward with that commitment. And the actual disbursement is expected to happen in the next 3 to 4 weeks periods as well.
Great. Thank you, Yuri. And that's a couple of really important points that you just shared. I think one is the dynamic nature of this, that when you're taking on a new commitment as a government, to start smaller and then expand over time. So starting with, we're going to say we can cover 20%. We have a short-term plan, a medium-term plan, and a long-term plan to make sure that there's alignment with financing. And then when you have multiple financing sources, there could be some fragmentation, and it's hard to get everyone aligned behind those commitments. And you're trying out different things, it sounds like, in Ethiopia to have more pooling and harmonization to bring the funding sources together behind that commitment. So thank you for that experience. Elizabeth, I'm going to turn to you. And so you left us with the package that was defined for the health promotion and prevention. Is that the package that's going forward, or what's happening today?
Yeah, so it's not too different from what is happening in Ethiopia. When it comes to defining the package, I mean, there was a lot of enthusiasm, but, you know, when it comes to financing, then, you know, the cold feet, let me just call it that, you know. And that is what is happening in Ghana now. So there's consensus. We have this 68 pack and services that has been defined. We actually went ahead to, even though these 68 services are not covered in the NHIS package, are there any other alternative sources of funding for some of these services? And like I say, I mean, we saw in the previous example, a lot of fragmentation, different, we had about 32 or 34 different, you know, bits and pieces of things happening here. You know, you have an NGO supporting probably just screening for anemia in pregnant women, something, you know, very fragmented, you know, funding sources. So that has been documented, but if we really want to achieve UHC, that is not the way to go. We need to find a way of really pulling all of these resources together and streamlining it. If we have to bring it all together and run it through the NHIS package, or, you know, come up with a different mechanism for ensuring that the coverage is nationwide, then that probably will be the way. So that is what is being done now. But the in terms of moving forward with the 60 package that we have put together, again, the government is saying that, yes, we know that we cannot include all the 68 onto the NHIS benefits package, you know, at a go. Let's start gradually. And so we facilitated a meeting between the service delivery agencies and then the purchasing agencies. So we had the Ghana Health Service, the Christian Health Association, private health providers, CEOs, and this was a very high level engagement. So we had the CEO of the National Health Insurance Authority coming together with the Director General of the Ghana Health Service, the Director of CHAG, and then the leadership of the private sector facilities. And the consensus from that meeting was that let's take it slowly. Let's take it slowly. So what has been agreed now, and we are in a political season in Ghana now, the government must be seen to be doing something. So they have agreed, you know, to take just a little bit of what has been done for now. So as a short-term strategy for including preventive services in the NHIS package. So we have, I think there are just about 4 services: screening for hypertension, diabetes, BMI, counseling. Yes, just about that. That has been agreed. And we are working to define the modalities for how this will be delivered. The idea is to deliver this through what is being referred to as the annual health check. So, and it's going to be free across board. It doesn't matter whether you hold an NHIS card or not. It's also being used as a means to increase NHIS enrollment. So during your birth month, you are allowed to visit any health facility to get screened for these services for free. And then the benefits package will cover it. So that is, I mean, the first step, or what we are calling the short-term strategy to getting the preventive services onboarded onto the National Health Insurance Scheme. And then there's still commitments to actually develop a methodology to cost the entire package that has been defined, and to design a pilot to test some provider payment mechanism, you know, as a medium-term measure. And then once we have learned some lessons from that pilot phase, then we would proceed to the long-term, you know, measure of actually now bringing everything, you know, incrementally into the NHIS benefits package. So that is where we are. We are currently now moving on to the annual health check. We are calling it AHC. That is going to be launched. I think it's 29th of this month. It's going to be launched. So Accelerator is supporting the National Health Insurance and then the Ghana Health Service, you know, to do a lot of sensitization, public awareness creation. You know, it's a whole lot that is going on. And you know, because it's the political season, the politicians are tagging along, you know, and all of that. So yeah, that is where we are.
This is the reality, right? And I think I like the point that I was starting the session saying about the politics of expanding commitment, but in this case, the politics is in reverse, that using the expansion of commitment in an election season can be useful and beneficial to both sides. And you also shared some other approaches for the government to mitigate risk of expanding commitment. So having a much larger process to define a larger package, but then starting smaller incrementally, piloting, doing some additional costing. So there are ways to mitigate the risk of expanding commitments. Kaki, now I'm going to go back to you. You gave us some preview about how this package for outpatient rehab services is being operationalized and purchased in Georgia. Can you share a bit more detail how that's going, and have some of the cost estimates that you did? Are they playing out in practice? Where do things stand today?
Yeah, I mean, we actually made a cost estimate and budget about which amounted up to 3% of the then existing healthcare budget. Said if you add the 3%, which was about 30 million lari in national currency, this will be, let's say, enough to like about 50% going to the outpatient rehabilitation services, 50% going to acute and subacute inpatient rehabilitation services. So that was the projection that we did based on the utilization data of medical conditions, including these priority health conditions, like diagnosis, ICD-11-10 diagnoses that are included in specifically neurologic conditions or multiple trauma fractures and orthopedic conditions. And based on that, estimated what will be the need based on the global evidence and as well the local evidence of, for example, what percentage of stroke patients would we need the outpatient rehabilitation, what subacute and acute rehabilitation, and so on. Based on that, it was but again, this was like 30 million, but government decided to include in the first year only outpatient rehab, considering the high level of uncertainty that related to the absence of utilization data. Yes, I mean, we convinced them that this was the best, let's say, best possible precision that is possible in conditions of absence of the data, that we did these predictions or cost estimates for the budget or rehabilitation service, but they still preferred to use the more cautious approach to see that, and as well, they also asked us to help with the other parts that will also help to manage the utilization of the services, considering that in the absence of standards, national guidelines, I mean, each massage parlor may claim that they are rehabilitation providers, and they register them as, like, I don't know, medical. And we are not the professions like physical therapists and occupational therapist professions, specialties are not regulated professions in Georgia. That was another issue that we also initiated in cooperation with WHO, with the Accelerator, of course, project, is also helping the country to develop competency framework and also look at the human resources strategy that is should be finalized with that, which is very important point. But the idea was as well to tie it to like some kind of pre-authorization procedure when we're purchasing, that those, especially those that require repeated rehabilitation sessions to be financed from the public purchaser, would be evaluated by the independent commission, whether they are the ones that are basically receiving, because the idea is to have direct resources to those that are in most need. So, and instead of like giving to the same patient that they may not benefit from repeated rehabilitation money for repeated sessions, basically trying to link that to the outcomes. And that was another request. And we also provided them with functional assessment tools that should be included as part of the purchasing decision and pre-authorization decision. So that's one thing, utilization control or management lever that now the purchaser has. And another is the minimum requirements for the rehabilitation providers, that each rehabilitation provider that want to participate in the program should satisfy. That's another thing. And of course, patient eligibility criteria was also developed. Along, we helped as well the experts groups to experts panel, national experts panel, to facilitate the process of developing the national guidelines for these specific priority conditions that we developed and care standards. So this has been a complex exercise, right, to convince the government this is like what you do. And it also used for the advocacy with the other parts of the ministry, like financial guys, and also with the Minister of Finance, Minister of Economy, the arguments as well, which I forgot to say that one of the key advocacy points was because it's a governmental decision, it's not just Minister of Health decision, to direct 30 million or whatever it is for these specific services as well, was that, it is value for money because it will improve the value of money that you already spend, for example, for treating the stroke or treating the artificial joint replacement, providing for the population, but not financing rehabilitation for the same patients, which basically turns into to say it mildly, non-optimal outcomes for these patients, because the stroke patient then still ends up with multiple disabilities because the rehabilitation service were not provided when they're most needed. They would most benefit the most the patient, or after the joint replacement, artificial joint replacement, which costs a lot, the people were not receiving any rehabilitation service to achieve independent living, improve independent functioning. So this has been some of the processes, and we hope that the ministry is committed implemented now based on the actual utilization, and also designed for them the monitoring and evaluation instrument. And once they do the assessment of the results of the 2023 program and 2024 program, they're gonna, at least the political commitment is that from the next year they would expand it to the other conditions, and also they expand it to the other levels of care, or basically inpatient, to include as well the inpatient rehabilitation. So that's where the processes we are. We did the costing for them, and we did the costing based on like differentiated scale, like mild, moderate, and severe cases. But in the beginning, again, they chose a very simple approach. They averaged. They took only just for outpatient rehabilitation, and they averaged across the board and said, okay, it's basically inviting the providers to share the risks, whether it's for the case mix. So basically, that has been, but they promised that based on actual utilization, they will revert back to the proposal that was presented to them with the budget and costing that has been based on this kind of meticulous exercise that I described earlier. Over to you.
Thank you, Kaki. That's really, I think, really helpful. You shared this kind of risk mitigation approach being incremental. So starting smaller than the original package that was proposed, starting smaller commitment as one way to mitigate risk. But then you brought another really important one, and that is using purchasing instruments to mitigate risk. And so to share risk with the patients on the one hand, right, using prior authorization for services through the provider payment rate setting, sharing some of the risk with the providers. So this idea that cost and utilization dictate your budget impact is not the end of the story, that we have other instruments that can actually help to mitigate the budget impact, and purchasing and provider payment is really the next chapter of this story that I hope we get to talk about next time we're all together. I think are we going to be able to take a few more minutes, or I know we got a little bit of a late start. Should we do a round of questions?
Yeah, we've got 5 minutes anyway.
Okay, let's, I don't know if you guys have some questions that are coming in online, if there are questions in the room. We'll take a few, and then we're gonna invite the panelists to pick and choose what they respond to.
I'm not seeing much for questions online at this point, but anybody online is welcome to submit questions to the panelists. And maybe we take some in the room to start.
Go ahead. Well, thank you so much. There's a lot of notes here, and I had a couple of questions. I think one of the introduce myself. Oh, apparently kind of apps global. I work on the LHS project, PhD now. Here, let's move on. So this is a very clear. All of the discussions here is very, very clear. This is very complex. Very complex. A lot of moving parts. There's political angles. Research data is useful. One of the things that I think I'm taking out of this is that there is an iterative process. There is an expectation that we start small, we start from something that we can manage. But then in iterative adaptation, my knowledge is that there's something about celebrating a quick win, because that then tends to generate some sort of momentum that people want to, especially when it's a complex case and there are a lot of stakeholders, they kind of want to feel like, okay, we are winning. And then they want to invest or push it even further. Can you kind of describe whether we are in that phase here in any other countries? And what are some of those quick wins or early wins that you think you want to celebrate?
That's a great question. I think we'll take several, and that's a really
great
question.
Yeah, thanks so much for these presentations. It's really great to get an update on the country. I have a question. In my limited experience with these types of packages, it's what about, have you decided, or have you a design or strategy already in place for monitoring, like an annual or biannual assessment of costs and utilization? And just thinking about the Georgia example, for example, that, there's an opportunity to course correct at some point, and I'm just wondering if you already put that in place.
Any other questions from the room or online?
That's my second one.
Please.
Thank you. My second one has to do with something you said at the beginning, Cheryl, about all of these 3 cases are built on existing. There was already an existing kind of structure or discussion in place, and we didn't kind of R4D or the accelerator didn't invent anything totally new. Can you say a little bit more about what you mean, especially in the Ghana case? Because I know that in Ghana, for example, the NHIA and expanding that package, there has been a long discussion coming. So at what point did we come in specifically for SME, and what were the prevailing economic and political, what was that prevailing economic and political environment that made us feel like this is the right time to do it? Because that's kind of how most countries think about these analyses. Right? That's the second question.
Great, thank you. So unless there's anything else online, maybe, so the three that I heard, I'm gonna invite the panelists to have their last word, 1 or 2 minutes to respond to whichever of these questions you would like to respond to. But there's a question about, out of all of this, what are the quick wins? Have there been any examples of quick wins that will show progress and that can keep the process going, or are any anticipated? The second question I heard is, what is the tipping point, especially in Ghana, that when the discussions about the package have been ongoing for so long, what actually was the tipping point? What was the role of the project in helping to get to that tipping point? And then the last one was about monitoring and evaluation. What are the processes in place for monitoring and to making sure that if you need to course correct, you can, given that all of the countries have taken this incremental approach, starting small, what's going to let you know that you haven't started too small or too large? So I'm going to reverse the order. Akaki, I'll start with you, and then Elizabeth, and then Yodi. For the very last word, Yodi. I hope that's okay.
Yeah, just quick wins. I mean, I would say first of all, to present the data that it worked, but also the most important, I would say, personal stories that, people were not able to afford rehabilitation before, and now they can. So that has been, and we actually, and ministry itself did the clips that then were like about these personal stories and video clips, and then they were circulated as one of the achievements in terms of the universal coverage and so on. I think everybody was happy with that. So including the governmental stakeholders. I'm not even saying that, of course, those that are defending the protecting or promoting the patients' rights or their families and so on, these organizations have also been quite active in that. And of course, in communication strategy, increasing the awareness regarding the availability of the services has been one of the key recommendations that has been also provided. And hopefully, as the program progresses, the awareness will increase as well, not only with the population, but also with the medical providers, because many of them does not even have any information that this kind of services are now publicly funded. So this is one thing. And as I said, with the negotiation advocacy with the financial ministries of finance and economic arm of the government, this is really about the value for money and demonstrating that this many people were served and their functional independence and the daily functioning increased and improved, and then their productivity losses have been prevented and so on. As of the monitoring and evaluation, I could say that the accelerator program just ended in June, but before that, we did the implementation research of actually how the program was implemented, and recommended, based on this research, recommended the actual improvements to the program, adjustments, part of which have been already either adopted or are in the process of adoption. And we also recommend the monitoring and evaluation instrument that once the program is finished, but the purchasing agency and the ministry will use to assess the effectiveness of the program at the end of the year. And it's like annual assessment, and this is like could be one of the examples of how they need to evaluate the old programs, because generally there is a major problem with health information systems and coherence of these systems and digital health integration throughout the other services and throughout the national health system. But we also suggested the ministry, and they're using it as an example how this could be well done in optimal manner as using example of rehabilitation services. So I think this will also help. We'll see. I mean, at the end of 2024, the agency should come up with an implementation report. We'll see whether they had used all this stuff and do it independently. We helped build their capacities, that now it's up to them.
That's a great point to end your intervention on. Elizabeth, would you like to pick up any of these questions or just your own final last words?
Yeah, maybe just a little bit on the quick wins. We know that we know that Ghanaians, we are not really the health check kind of people looking at prevention. We only go to the health facility when we are sick. And so being able to roll out this annual health check where you would be in your house and receive an alert in your birth month that go for screening, go for this. And being able to, you know, say that this number of people have been screened, early detection of hypertension, you know, being able to manage this number of cases, being able to prevent this, you know, would be something to really celebrate. Yeah. In terms of when did we come in, I think, like I mentioned earlier, it was general knowledge that the NHIS benefits package was heavily, you know, curative. But then at the beginning of Accelerator, the Ghana didn't have a fully defined essential health service package. There was a draft that was developed. It was not in the form that stakeholders wanted. So the process stalled. I understand, you know, there was not enough engagement. The process had stalled. So when we came in, there was this draft Excel document that was available, but we had to deploy, you know, a broad process to now have a document and it's a package that is accepted by all. It's an integrated package that is endorsed by all stakeholders. And harmonizing that with the benefits package really brought out, you know, what words would I use? How big the problem was. So we knew that there was a problem that preventive services are not really covered, but the magnitude of it, we were not, I mean, we didn't know until that harmonization and alignment exercise took place. And then it triggered that the need to actually really start talking about this more seriously and really ensure that it gets onto the agenda.
Thank you. With that, I would consider that a win. Maybe not quick, but definitely a win. Yeah. Thank you, Elizabeth. And Yodi, finally to you, if you'd like to pick up one of these questions or just give a few final thoughts from your experience.
Great, thank you, Cheryl. Thank you for the question as well. Maybe I can say one quick unity is there is a huge perception within the Ministry of Finance thinking that health is well funded. So this analysis and the finding and the required readiness from the government side to take over full ownership for exempted service, specifically for maternal program, was an eye-opening for the top management within Ministry of Finance to see the importance of, one, health is not well funded, two, the government should be on the driving seat for the resource mobilization and allocation when it comes to providing the healthcare service in between in a full manner. So that was like, for me, like a big quick win. At the same time, the government being awakened, beside talking about domestic resource mobilization here and there, this is the time they start acting on it and also strategizing their action for the coming year's period. In related with that, and also one key point I would like to emphasize is it's really great that we're able to create a momentum from the government side to take full ownership on the resource mobilization and allocation, but at the same time, we should be very much considerate of the physical constraint that many countries are facing in LMI setups. So when we push for certain program like family planning or MNSH through co-financing or match funding, the government might give us green lights to commit more funding in order to leverage what's available from the donor side. But one thing that we experienced is that additional funding is coming at the cost of other programs as well. So there needs to be a balance when we transition from the donor funded to the domestic resource mobilization, taking into consideration how much feasibly the government can contribute and also making sure that other services shouldn't be compromised for certain programs as well.
Thank you, Yodi. What an important point for us to end on, these very real trade-offs and who's making the decisions about these trade-offs. So this is fantastic. If I could just give, I mean, our panelists did a fabulous job wrapping up. And we prepared for this, and I've spoken to these panelists multiple times. I still got new insights today, so I hope you all did too. And just a few things that really hit home that this is not a technocratic process by any stretch. And all of the priority setting and all of the tools and analytics that are out there, at the end of the day, this is a value judgment and a political process. And who's at the table matters. And we heard 3 great examples of very wide stakeholder processes that got to some very good consensus about how to make the kinds of trade-offs that Yodi's talking about. I think the other point, we didn't talk so much, we talked so much about the health game, but all of the arguments that had to be made on the finance side, the arguments to the Ministry of Finance about how health is not actually overfunded, and the kinds of arguments that you were talking about, Kaki, about actually you'll magnify and amplify your current investments by adding these other services. And then how to do this in a more iterative way to not take on too much risk, and all the different ways that we heard the countries are managing that, to not overcommit and to do this incrementally, to build in the purchasing and provider payment thinking at least early on, and then maybe get to the point that you did in Georgia to actually use those levers to make more services affordable. And I think that that's the cycle, the virtuous cycle that we want to get on. And then finally, we heard a lot about the real life stories. So the analytics, health technology assessment, all of these things, that's not what moves this. It's the people who benefit from the services and come and say they benefited, people who get a health check for the first time in their birthday month. It's about the people and what they're benefiting from this, how to tell those stories, how to make sure that those needs are being met, and that information gets to them and then gets communicated more widely. So thank you all for such a great session. Thank you so much again to the panelists, and I hope you enjoyed the posting off, and we're going to put a little bit longer today, but thank you for joining the session.
Thank you, Cheryl, for
Thank
you, everyone.
Thank you, everyone.
Yodi,
Thank you, everyone.
Staying late, yes, staying up late at night in Georgia and Ethiopia.